Hello, all. I'm Dr. Maria Gardani, and I will talk to you about insomnia. This is a short segment from a 3 hour lecture that will cover sleep and circadian disorders, including assessment and interventions. So, based on DSM-5 criteria for the diagnosis of insomnia, one experiences insomnia disorder when they express a dissatisfaction with their sleep quantity or quality, having one or more of the following symptoms, such as difficulty falling asleep, staying asleep, or waking up too early in the morning. This sleep disturbance should also be accompanied by significant distress in daytime functioning areas such as occupational, social, educational, or academic. This is a change from DSM-4, where it was primarily considering nighttime symptoms. The sleep difficulty should occur for at least 3 nights per week and should be present for 3 months, despite adequate sleep opportunity for the individual. For example, a new mom that cares for a baby and having experiencing a lot of nighttime awakenings is not experiencing insomnia. The insomnia should not be explained by coexisting mental disorder or other medical condition. Also, please note here that now the DSM-5 using insomnia and insomnia disorder interchangeably, and also is moving away from what used to be characterized as primary and secondary insomnia, but now adopts the terminology of comorbidities. So now insomnia is considered as a disorder on its own right that can coexist or be comorbid with other conditions. In addition to DSM-5, we're using the International Classification of Sleep Disorders, now in its third edition, and also the ICD-10. The ICD-11, when will be endorsed in January 2022, will be aligned with the DSM-5 criteria for insomnia, and these also, based on new research findings, will strengthen the association between insomnia, anxiety, and depression, meaning that patients with the new criteria will have diagnosis of other mental conditions. Insomnia is one of the foremost sleep complaints individuals go into their GP, other than pain. At least 40% of the general UK population experiencing a sleep complaint, and GPs reported that at 80% of them will see someone with a sleep complaint at least once a week. The population prevalence of insomnia is different between countries and studies, with the general consensus that this is between 10 and 20%, whereas in older adults, this is over 20%. Insomnia prevalences in other groups, such as those following acquired brain injuries, are found to be higher. For example, in a study in systematic review and meta-analysis we conducted, we found that the pooled prevalence of insomnia was 38.2 following stroke, or up to 62% in those following mild traumatic brain injury. Insomnia is associated with a multitude of health problems ranging from anxiety, depression, suicidal ideation, obesity, cancer, dementia, cardiovascular diseases. So it's a high comorbidity and is found in the wider population at large. Also, it's important to note here the bidirectional association between insomnia and depression, as insomnia has been identified to be predictor for the de novo onset of major depression in two meta-analyses. In a more recent systematic review and meta-analysis, insomnia was found to be a predictor for mental disorders, and that was significant for depression and anxiety in shorter follow-up studies, for anxiety in longer follow-up studies, but not for depression in longer follow-up studies. It's important to note in these studies that the 11 main studies that pulled together in this meta-analysis comprised of participants that had no other comorbidities. They were pure, as the researchers characterized them. So we see this onset of sleep of mental disorders following insomnia later on in the studies. Also, some data suggest that patients with insomnia are also at greater risk of alcoholism, psychosis, and cardiometabolic diseases. Several research groups suggested etiological or psychophysiological models of insomnia. Most of these are implicitly or explicitly based on the so-called 3P model of insomnia that put forward by Spillman in 1987, which postulates that predisposing, precipitating, and perpetuating factors, here graphed with blue for the predisposing, green with the precipitating, and yellow for the perpetuating factors, are involved in the etiology of insomnia. For example, predisposing or premorbid factors could be genetic influences or personality traits such as neuroticism or maladaptive perfectionism. Gender, as we know that female from 1.5 to 1 ratio actually experiencing higher um, instances of insomnia compared to males. So as we see in this graph that is adapted from a late paper by Spillman, we see that following these predisposing factors, an individual then may experiencing what we call acute insomnia. This is acute or transient insomnia that has a duration of less than 3 months, but a frequency of at least 3 times a week of symptoms such as difficulty falling asleep, staying asleep, or waking up too early in the morning. An individual, when they're undergoing a major life event that is stressful, may experience acute insomnia. This life event, the stressor, is what we call the precipitating factor that contributes to this difficulty in their sleep. So, moving on from that, and as we see that this precipitating factor is dealt with by the individual now adopts maladaptive coping mechanism to um, be able to cope with the sleepiness, the experiencing such fatigue. These are the perpetuating factors depicted here in yellow. This can be going to bed too early as they're too tired, avoiding social events, feeling again that they will be too tired to attend, or worrying about their work, especially as their memory or concentration be affected by a lack of sleep. So, an individual, we know that now that the precipitating factor, the life stressor event, go away, and these should return to the good sleep wake patterns. However, a large proportion of people with acute insomnia, about 20%, will develop chronic insomnia. And as we see in the graph here, this now moves over the clinical threshold, and the main reason for that are these perpetuating factors. All these maladaptive habits the individual took on in their lives to cope with the sleepiness and the tiredness and the fatigue now are the main drives for their insomnia. This model really interlinks with the cognitive behavioral therapy for insomnia, which is the main psychological intervention for insomnia. And its effectiveness has been demonstrated over the past 3 decades in different settings, delivery methods such as one on one, online, using books, using the telephone in the past, or text messages even. So this is a shorter CBT course comprised of 5 weekly sessions that can be up to an hour each. However, based on the group you're working with, these will be adapted to their abilities and based on the memory, concentration, and focus. So these 5 weekly sessions will cover, in this order, sleep education, psychoeducation, sleep hygiene, relaxation practices. Also, they will move on to the more behavioral components, such as sleep scheduling. This will comprise stimulus control, sleep restriction. We move on then to the dealing with the thoughts and worries, the more cognitive part of CBT, and also ways to develop a stronger sleep-wake pattern, how we can boost this homeostatic process. In the last session, therapists with the individual or the group that will review their progress, and they will try to set goals on how they will maintain this good, strong sleep pattern in the future. Following these, we will now discuss each of these sections in detail, and they will give you more detailed ways in how you can tailor these for different groups and different settings. Thank you.